Hello all, myself Dr. Farhan Sheikh, consultant pediatric intensivist at Rainbow Children's Hospital, Manjara Hills, Hyderabad. I'm going to speak on the topic of pulmonary mechanics. I'll try to keep this topic as simple as possible. I'm going to apply the concepts of pulmonary mechanics at the bedside by showing some interesting videos and animations so that it becomes more easy for all of us to understand the clinical utility of pulmonary mechanics. So as we know, mechanical ventilators deliver gas to the lungs using positive pressure at a certain rate. The amount of gas delivered can be limited by time, pressure, and volume, and that's why it is called as pressure limited or volume limited breath. And the duration over which this gas is delivered can be cycled. That means the inspiration ends and the expiration begins. Once the time is finished, then it is called time cycled, pressure cycled, or flow cycled. Normally, most of the ventilators have time cycling and flow cycling, but in assist control, pressure control mode of ventilation, we can have pressure cycling also. These things will be more discussed in more details when a lecture on ventilatory modes will be delivered. So when it comes to respiratory mechanics, there are measured parameters like pressure, flow, and volume. So these are measured inside the ventilator and they are displayed on the ventilator screen. And then there are calculated parameters like compliance and resistance. So as far as the outline of this talk is concerned, we are going to divide this talk into four major headings. We are going to discuss pressures, all different terminologies we used for various pressures like peak inspiratory pressure, plateau pressure, driving pressure, transpulmonary pressure. We will discuss all those terminologies and what does that mean and how to apply them at the bedside. Then all the terminologies pertaining to volumes like tidal volume, end expiratory lung volume, functional respiratory capacities, we'll see them. We will also discuss respiratory rates, gas flow, and time constant. We will also talk about compliance, elastance, and their bedside utility. So coming to pressures, the popular terms we all hear all the time is PIP, that is peak inspiratory pressure, plateau pressure, positive end expiratory pressure, driving pressure, transpulmonary pressure, transthoracic pressure, etc. So this is a schematic presentation of pressure time scalar. These scalars, loops, these kind of pulmonary graphics will be discussed in more detail in the lecture on pulmonary graphics. Here, for our understanding, we need to see that at the base, we have a positive end expiratory pressure above which a breath is delivered. And this is a PIP or peak inspiratory pressure in pressure control mode. While in volume control mode, again, on the top of positive end expiratory pressure or baseline pressure PEEP, where there is a pressure wave, but in volume control mode, as the volume is fixed but pressure is not fixed, we have two pressure peaks, PIP and P-plateau. So this is how in actual patients we can see we will have this difference. This is a volume control mode, and we can clearly see in volume control mode there is a PIP and P-plateau, and in pressure control mode there is a flat top with only PIP. So when we see this is PIP and P-plateau, and this gap between PIP and P-plateau is determined by the airway resistance. We will be discussing that in more details in later slides. So PIP is determined by airway resistance and flow, and plateau pressure corresponds to the available alveolar pressure. The distance between plateau pressure and the positive end expiratory pressure is nothing but driving pressure. So driving pressure is nothing but plateau pressure minus positive end expiratory pressure. We just need to remember this thing right now. In later slides, we will be discussing this in more details. So we have this particular area called alveolar pressure. And if we look at a pressure time scalar in volume control mode, as I said, in volume control mode, volume is constant. So you have two pressures at the peak of inspiration, PIP and plateau pressure. And if there is a situation of increased airway resistance, like bronchospasm, like bronchial asthma, then you will see the plateau pressure doesn't change because alveolar pressure is not changing. But because of increased airway resistance, the PIP is taller. So PIP is taller, but plateau pressure is remaining same in situations of increased airway resistance. While in situations of poor lung compliance, like pulmonary edema, which can be cardiogenic pulmonary edema, or it can be because of ARDS, you can see that there is not much change between the PIP and P-plateau. The gap between PIP and P-plateau is same, but overall the height of P-plateau as well as PIP is elevated as compared to normal lungs or normal pressure time scalar. So both PIP and P-plateau are elevated. So this is a sign of poor lung compliance. So if you look at actual patient, we can clearly see that in this particular situation, we can see here, and we can see in this video, we can compare here also we have a peak pressure of 37, and on the right side also we have a peak pressure of comparatively same 37, 38. But on the left side we can see there is a big gap between PIP and P plateau, indicating there is a situation of increased airway resistance, while on the right side there is a very little distance between PIP and P plateau. So both PIP and P plateau are elevated and the pressures are high. So on the right side, you have a situation of poor lung compliance. On the left side, you have a situation of increased airway resistance. Now, what is positive end expiratory pressure? Positive end expiratory pressure is a continuous positive pressure applied even during expiration to maintain alveoli open, and that is called as positive end expiratory pressure. So we know Laplace law, that is pressure is equal to 2T divided by R, where T is surface tension, R is radius, and pressure is the pressure required to open the alveoli. So you can see the radius is inversely proportional to pressure. That means when the radius is small, when the alveoli are completely collapsed, higher pressure will be required to open those alveoli. So we can compare this by the analogy of inflating balloon. When we inflate the balloon, initially when the balloon is totally collapsed, we need much higher pressure to open that balloon. But when the balloon reaches a certain dimension, inflating the balloon further is very easy. And then at the end of complete expansion of the balloon is now overstretched, and further expansion of the balloon becomes more difficult, and higher pressure, less change in the volume will happen. So similarly, if the alveoli are completely collapsed, the radius will be minimum and very high pressures will be required to open it. Thus, pressure is inversely proportional to radius. So when you look at pressure volume loop, you will see that initial part, very large change in the pressure is yielding very little change in the volume because most of the alveoli are collapsed state. But after a certain point, most of the alveoli are now in a semi-open condition. So their radius is optimum and very little change in the pressure is achieving very good change in the volume. And then again a point comes where the most of the alveoli are now opened sufficiently, or they are over distended rather, and further change in the pressure is not going to yield much change in the volume. And then the expiration starts. Thus we have a lower inflection point and upper inflection point, and we have a zone of de-recruitment, zone of hyperinflation or overinflation, and a safe zone. And when we titrate positive end expiratory pressure or PEEP, we try to keep the PEEP between the lower inflection point and upper inflection point, somewhere in between, where we have least pressure required to achieve best change in the volume. That is nothing but good compliance. We'll discuss compliance in later slides. Now, during spontaneous breathing, when the patient is not intubated, the patient is spontaneously breathing, we can see the schematic presentation of lung. This is the major airways, trachea, bronchi, and this is the alveolus. This is just a cartoon schematic representation. This is the visceral pleura. This is the parietal pleura. This is the chest wall, and this is the diaphragm. So normally, this is the intra-alveolar pressure. So the pressure inside the alveoli, and it usually equilibrates with the atmospheric pressure at the end of inspiration as well as at the end of expiration. The alveolar pressure becomes equal to the atmospheric pressure. This is the pleural pressure. This is the pressure between the parietal and visceral pleura. So normally, the lung has a natural tendency to collapse inside on itself, and surface tension inside the alveolar walls contributes to 2/3 of this tendency of the lungs to collapse, while 1/3 of this tendency of the lungs to collapse is because of the natural elasticity of the lung parenchyma, that is elastin fibers. And in patients with very bad emphysemas, we see that is a loss of elastin in emphysematous lungs, and that's why the lung loses its tendency to collapse and becomes hyperinflated. So this is the situation. So lung has a naturally tendency to collapse. This we need to remember as of now. And our chest wall normally has a natural tendency to expand or go out or move out. And that is very important, because now we can see the outward direction movement of parietal pleura along with the chest wall is working against the inward movement on the visceral pleura, because lungs are having a tendency to collapse inside, drawing the visceral pleura inside. Parietal pleura is being drawn outside with the chest wall. There is a negative pressure which builds up within the pleural cavity, and this is usually around -3 to -4 centimeters of water at resting age stage at the end of expiration. So at the end of expiration, you have a -3 to -4 centimeters of water of negative intrapleural pressure during spontaneous breathing, when a patient is not on ventilator or not on positive pressure ventilation. When the diaphragm contracts, when the inspiration starts physiologically, when you are breathing, then what happens is the parietal and visceral pleura are pulled against each other further apart, and this will lead to increase in the negative intrapleural pressure further. So which was -3 to -4, now it may increase further to -7 to -9 centimeters of water at the peak of inspiration. So this is how the negative intrapleural pressure changes during inspiration and expiration. During expiration, it will be somewhere at -3 to -4, and during expiration, it can increase further to -7 to -9. And as we know, with Boyle's law, volume is inversely proportional to the pressures. So when the pressures are falling, the volume expands, and as the volume expands, the air is basically entrained in the alveoli, and the gas enters from the atmosphere through the airways into the alveoli, and that's how inspiration happens. So if we compare various pressures, the lung volume, intra-alveolar pressure and intra-pleural pressure, we see that at beginning of inspiration, the lung volume starts increasing, and intra-alveolar pressure is actually falling a little bit, because there is a pulling of the diaphragm, and negative pleural pressure, as we can see here, from -4 to -5, the negative intrapleural pressure is building up to -7 at the mid of inspiration, at the peak of inspiration, and this is building up a lot of good lung volume and some negative intrapulmonary pressure. And at the end of inspiration, at the peak of inspiration, this was mid of inspiration, at the peak of inspiration, we see maximum amount of lung volume entrained into the alveoli, and we can see here the alveolar pressure is becoming zero again. So at the peak of inspiration, the alveolar pressure equilibrates with the atmospheric pressure, and you have maximum intrapleural negative pressure of -7 to -9 centimeters of water. Now expiration starts, the volume starts falling, because now the air is exhaling out of the alveoli, and you see the intrapulmonary pressure also starts rising, and the negative pressure is now little bit on the, it is going back from -7 to towards -4, -5. And then at the end of expiration, all the volume is out, very little volume is remaining in the alveoli, and the pleural pressure is back to -4 to -5. And we can see at the end of expiration, once again, the alveolar pressure is zero. It is again equal to the atmospheric pressure. So there are 2 points where the alveolar pressure equilibrates with the atmospheric pressure, at the peak of inspiration and at the end of expiration. And we have this lung compliance, we can see here, we have this chest wall compliance, and this is the average of chest wall as well as lung compliance. And this is our functional residual capacity, which is the sweet spot at the end of expiration. We can say, if you're not intubated, then at the resting stage, and if you're at ventilator, then at 0 PEEP, you can say, or at very minimal negligible PEEP, you have a functional residual capacity. One more thing which can notice is that the chest is far more compliant than the lungs. So this is lung compliance and this is chest compliance, and you can see chest is much more compliant as than the lung compliance. So normally the pleural pressure is always negative, as we also already saw, but it can become equal to the atmospheric pressure when there is a penetrating chest injury, like a stab injury, or it may actually become positive during tension pneumothorax, pleural effusion, increased intra-abdominal pressures like severe ascites or obesity or spinal or thoracic cage malformations. So at resting stage, there is negative intrapleural pressure of -3 to -4, which we already discussed in previous slides. And after intubation, when we intubate, we need to apply a pressure of around 3 to 5 centimeters of water during expiration, which we call positive end expiratory pressure, to overcome this negative intrapleural pressure of -3 to -4 centimeters of water. Now, on any ventilator, when you look at the ventilator screen, you will have these numbers. This is a P peak or PIP. This is positive end expiratory pressure like PEEP. Then positive pressure. These numbers are always displayed on the ventilator screen. You look at any ventilator, you will have these numbers. We need to understand that these are called as airway pressures, which is inspiratory pressure, expiratory pressure, and these pressures are total pressures. So this pressure is the pressure required to expand the lungs plus the pressure required to elevate the chest wall. It is not only the pressure required to expand the lungs. It is the pressure which is displayed here to expand the lungs as well as to display the chest wall outward. So now this brings us to the next topic of transpulmonary pressure. This is transpulmonary pressure is the actual pressure which is spent in expanding only the lungs without the chest wall included in this. So this is calculated by taking the difference between airway pressure minus pleural pressure. Airway pressure, as we know, is nothing but the alveolar pressure or airway pressure, which is displayed on the ventilator screen. And the pleural pressure is measured by various techniques. One commonly used technique is esophageal pressure. I don't want to go into more details about that because that is not in the scope of my talk. But we need to understand that there are various techniques of measuring the pleural pressure. One of them is esophageal pressure. And when you take difference between the airway pressure, which is displayed on the ventilator screen, and the pleural pressure, you get transpulmonary pressure, which is the actual pressure across the alveoli and used to open only the lungs without including the chest wall in the equation. So this is the transpulmonary pressure, the difference between the alveolar pressure and the pleural pressure. So the pressure required to distend the alveoli or transpulmonary pressure is the difference between airway pressure and the pleural pressure, as we saw just now. In 2004, Gattinoni had actually demonstrated that in patients with normal chest wall compliance, when the chest wall is normal, there is no obesity, ascites, intra-abdominal hypertension. In those cases, suppose if you have applied a peak airway pressure of say 30 centimeters of water, then in those cases, 25 centimeters of water will be used up in opening the lungs, and only 5 centimeters of water will be spent in elevating the chest wall, and the transpulmonary pressure will be somewhere around 21 centimeters of water, which is all right, acceptable. But if you have a situation where you have a poor chest wall compliance, like severe chest wall edema or ascites, intra-abdominal hypertension, or severe obesity, in those cases, when you apply the same plateau pressure of 30 centimeters of water, here now, most of the pressure, that is 50% of the pressure, 15 centimeters of water is spent in expanding the chest wall or overcoming the stiffness of the chest wall, and only 50%, that is 15 centimeters of water of the pressure is used in expanding the lungs. So half of the pressure is wasted in overcoming the chest wall elastance, and half is used to open the lungs. So that's why it is important to find out exact pressure on the lungs, that is transpulmonary pressure, rather than looking only at the pressure which is displayed on the ventilator. Because if you look at the pressure on the ventilator screen, you will see 30 centimeters of water, but actually the lungs are getting only 15 centimeters of water, and remaining 15 centimeter is being used to expand the chest wall, which is actually not delivered to the alveoli. And this 30 centimeters of water is actually misleading. So in a clinical situation, if a patient has a normal chest wall compliance and your airway pressure displayed on the ventilator screen is, for example, 30, and your pleural pressure is, for example, normal around +4, your transpulmonary pressure will be 30 minus +4, that is 26, which is quite all right, which is quite near to your airway pressure displayed on the ventilator, 30 and 26. And you can ventilate the patient looking at the airway pressure displayed on the ventilator screen. However, if you have a problem of chest wall edema, there is a thick chest wall because of massive pleural effusion, obesity, ascites, or intra-abdominal hypertension, And in those situations, you have same airway pressure displayed on the ventilator screen of 30, but now your pleural pressure is not 4 because of intra-abdominal hypertension or obesity or ascites. Your pleural pressure is now plus 20, and your transpulmonary pressure is only 30 minus plus 20, that is 10 centimeters of water. So your airway pressure displayed on the ventilator screen is 30, but the pressure which is at the level of alveoli expanding the lungs is only 10. So this is a problem, and that is why it is so important to monitor transpulmonary pressure. So this is transpulmonary inspiratory pressure. This is during peak inspiration. We have taken the airway pressure at the inspiration and the pleural pressure at the peak of inspiration and taken the difference. This is called transpulmonary inspiratory pressure. Similarly, we can calculate transpulmonary expiratory pressure. So in a normal lung, in a poor chest wall compliance patient, suppose that you have applied a PEEP of 12. So on the ventilator screen you are watching, and the PEEP is 12. PEEP of 12 is sufficiently high for any child. But suppose there was obesity, ascites, or poor chest wall compliance due to severe chest wall edema, ascites, or intra-abdominal hypertension. And because of that, the pleural pressure in this child was plus 15 at the end of expiration. And then if you see the transpulmonary pressure, you had a sufficiently apparently PEEP of 12, which is sufficiently high. But if you calculate transpulmonary pressure during expiration, you have 12 minus plus 15, which is minus 3 centimeters of water. So the transpulmonary pressure is actually negative value, and negative value transpulmonary pressure means there will be actually atelectasis at the lung bases wherever there is a negative transpulmonary pressure. So that's a point of concern. And in this situation, then what we'll have to do is we have to first measure the pleural pressure by various techniques. For example, esophageal pressure monitoring, measure the pleural pressure, and when we find that it's a high like 15, then you apply a PEEP which is higher than the pleural pressure. So in this case, instead of 12, we'll apply 18 of PEEP. And now if you look at the transpulmonary pressure, it will be 18 minus 15, that is plus 3. And this positive transpulmonary pressure, positive value, will mean that the lungs will be kept open and atelectasis can be prevented. Thus, it's so important, particularly in patients with obesity, ascites, chest wall edema, wherever you're suspecting that your chest wall compliance will be poor, to measure pleural pressure and then titrate your inspiratory and expiratory pressures. So, as we saw now, transpulmonary pressure can be transpulmonary inspiratory pressure, that is a Plateau pressure displayed on the ventilator minus the pleural pressure which you measured at the peak of inspiration. You can have a transpulmonary pressure at expiration, that is positive intestinal pressure displayed on ventilator minus pleural pressure at expiration. So just like driving pressure which we saw earlier, which is Plateau pressure minus PEEP, you can have a transpulmonary driving pressure, that is transpulmonary pressure at peak inspiration minus transpulmonary pressure at expiration. So you can calculate this also. Further discussion on this topic is beyond the scope of this lecture, but these terminologies we are all supposed to know as far as the talk of pulmonary mechanics is concerned. There are some other terminologies also. So first we'll revisit the concept of transpulmonary pressure. So we have alveolar pressure, which is equal to the atmospheric pressure. Due to the opposing forces acting on the parietal and visceral pleura, as we know, the pleural pressure is usually minus 3 to minus 4. So transpulmonary pressure is equal to alveolar pressure or airway pressure minus pleural pressure. This we already saw. So generally, in a spontaneously breathing patient, it will be somewhere at around plus 4. This keeps the alveoli open. Now, this is something called as transthoracic pressure. Transthoracic pressure is across the chest wall. This is pleural pressure minus the atmospheric pressure. As we already saw, the pleural pressure is normally minus 3 to minus 4. So we can take minus 4 minus 0. So this will be minus 4. Thus, transthoracic pressure is equal to pleural pressure is also minus 4 and transthoracic pressure is also minus 4. So transthoracic pressure is also equal to intrapleural pressure. Thoracic pressure is equal to intrapleural pressure. Now coming to transrespiratory pressure. Transrespiratory pressure is the pressure across airway and the alveoli. And we discussed this already, that alveolar pressure equilibrates with the airway pressure at the end of inspiration as well as end of expiration. So both are same. So trans airway pressure is also known as trans airway pressure. So this brings us to end of the discussion on all the pressures, and we come to the next topic of our talk, that is volumes. In the volume, we have certain terms like tidal volume and expiratory lung volume. Functional residual capacity is also a type of volume. And then concept of stress and strain also will be discussed along with dead space ventilation. So at any certain PEEP, which may be 0 PEEP or a normal, some clinically applied PEEP, when there is a normal breathing going on at a inspiratory certain volume, that volume is called tidal volume. And when a deep inspiration is taken, then you have an inspiratory reserve volume and total inspiratory capacity. And after deep inspiration, when there is a deep exhalation, then you have a expiratory reserve volume. And at the end of deep expiration, whatever amount of volume left in the lungs is residual volume. Functional residual capacity is the amount of volume which is there in the lungs at the 0 PEEP when there is a patient intubated, or minimal PEEP, or at a spontaneous breathing in unintubated patient over which a patient is breathing normally. That is your FRC. This is your total lung capacity. And generally total capacity is 2.5 to 3 times the FRC. We know that the FRC is a sweet spot between expanding chest wall and collapsing lungs. And this provides optimum diameter to the alveoli. It provides the optimum negative intrapleural pressure, and that provides distending pressure over the alveoli, which keeps the alveoli open at resting stage during expiration. And during subsequent inspiration, less pressure is required to open the alveolus. At the same time, the FRC also provides optimum diameter to the pulmonary blood vessels also for better perfusion. So FRC is a sweet spot at which you have got a very good optimum ventilation as well as perfusion. Coming to the concept of stress and strain. Stress we already saw. It is the pressure which is required to distend the alveoli or lungs. And this is the pressure, as we already saw, is the pressure calculated from difference from airway pressure and pleural pressure. Transpulmonary pressure can be inspiratory transpulmonary pressure, then that is Plateau pressure minus pleural pressure during inspiration. Transpulmonary pressure can be expiratory transpulmonary pressure, where it is PEEP, which is displayed on the ventilator screen, minus the pleural pressure measured during the expiration. So transpulmonary pressure is nothing but stress. Strain is what the elastic fibers are undergoing because of the stress which are applied over the lungs. That means the change which is happening in the volume over the top of the initial volume. Initial volume, that is the baseline volume, is FRC. So basically at strain is nothing but the tidal volume which is applied at the top of the FRC. That is the strain. Stress and strain are interestingly related to each other. So stress, nothing but transpulmonary pressure, is equal to K multiplied by strain. And strain, as we know, is tidal volume divided by FRC. And the K is also known as lung specific elastance. Now K can become equal to transpulmonary pressure if tidal volume is equal to FRC. So if this becomes equal to this value becomes 1. If this value becomes 1, then lung specific elastance becomes equal to stress. So lung specific elastance is nothing but the pressure required to double the size of the baby lung. So at FRC, if you are delivering a certain breath, a certain tidal volume, then you have this tidal volume divided by FRC as strain. This is your total lung capacity, which is 2.5 to 3 times the FRC. And this is the strain, which is ratio of VT divided by FRC. Now, when you introduce a certain PEEP into the system, positive industrial pressure, you are basically introducing a certain PEEP volume. And when you do that, you have an end expiratory lung volume, which is combination of PEEP volume plus the FRC. And the strain now can be calculated as ratio of tidal volume plus PEEP volume divided by FRC. And this is your end inspiratory lung volume from here. And we can see all the qualities of a good PEEP. So a good PEEP has resulted in some improvement in FRC, and that is the denominator of the equation of strain. It has also added some PEEP volume to the numerator of the equation of strain. So basically it has balanced out the equation of strain, neither increased nor decreased the strain. And at the same time, this PEEP is good because it keeps the alveoli open, as we know, and it makes, as per the Laplace law, the pressure required to open the alveoli subsequently during next breath will be easier. PEEP is also required to prevent atelect trauma and repellent cyclical deformation of the alveoli. Those things are also prevented by a good PEEP. And now it is balancing the strain also here. And this good PEEP is keeping the end inspiratory lung volume sufficiently away, safely away from total lung capacity. So these are all good qualities of a healthy PEEP or a good PEEP, which is balancing everything nicely. But if you applied excess amount of PEEP, then what happens? Excess amount of PEEP is going to increase the numerator much more than the denominator. So now the strain mathematically increases much more by excess amount of PEEP. And we can see here the end inspiratory lung volume is also almost touching the total lung capacity. So for example, if this patient is breathing at 30 breaths per minute, every minute 30 times you are hitting the total lung capacity, and this is going to expose this patient to severe volume trauma also. So this is a bad PEEP. A bad PEEP is going to expose the patient for volume trauma as well as increase the strain. So we can see that PEEP has a U-shaped relation rather than linear. Optimum PEEP works by expanding the alveoli. As per the Laplace law, it will require less pressure to open the alveoli during the subsequent breaths, keep them well aerated, prevent cyclic inflation, deflation during ventilation, and it prevents atelect trauma. And high PEEP leads to problems of volume trauma and excessive strain in the system. Now coming to dead space ventilation. Total or physiological dead space includes anatomical and alveolar dead space. So when there is an inspired gas that does not take part in the gas exchange, that is termed as dead space. This determines the fraction of the wasted ventilation. Schematically, we have instrumental dead space in any ventilated child. So you have an endotracheal tube, which does with the air within this is not going to participate in any gas exchange. Similarly, various things which are connected to the endotracheal tube like HME filter, ETCO2 module, or inline suction or catheter mount, they are all excess amount of dead space increasing items. Then anatomical dead space and alveolar dead space, and this is the part of the area which is actually participating in the gas exchange, which is the gas in the alveoli and acini. So you have a physiological dead space, which is combination of anatomical dead space and alveolar dead space. Usually in healthy people, alveolar dead space is very minimal, so mostly it is anatomical dead space. And anatomical dead space represents air that fills the conducting passage starting from the upper airway to the lower airway tract up to the respiratory bronchioles. And as I said, in healthy children or adults, alveolar dead space is negligible. Anatomical dead space constitutes up to 1/3 of the normal tidal volume. So whatever tidal volume we are delivering, 1/3 is constituted by the anatomical dead space. Bohr's equation is used to calculate physiological dead space. That is, Vd is equal to tidal volume into PaCO2 minus PeCO2 divided by PaCO2. PaCO2 is arterial carbon dioxide measured in the blood gas, and PeCO2 is the end tidal carbon dioxide measured from the EtCO2. And we know that if your patient has increased physiological dead space, as no normally physiological dead space is negligible, but in situations like bronchiolitis or ARDS or pulmonary edema, when the physiological dead space is increasing, the alveolar gas is also not participating in gas exchange. Then in that case, the instrumental dead space can be reduced by removing number of connections like catheter mount connectors, suction catheters, etc. We can take one example from this. Here, this child is on ventilator with the nebulization chamber, EtCO2 module, and inline suction. Child is having this kind of gasping breathing. And when we look at the ventilator, all types of asynchronies are there. There is double triggering here. And when we shift to volume control, we can also see that the child is also having significant flow starvation here. So these things you will be learning in the lectures on patient ventilator asynchrony and pulmonary graphics. So what I'm trying to say is the child had a problem of dead space ventilation leading to a lot of asynchrony and flow starvation. So what they did was they removed the nebulization chamber and EtCO2 module, connected the child directly to the ventilator. So this was creating so much of dead space in this child. So only this was removed and patient was connected to the ventilator, and you can see the patient is breathing comfortably now. There's no gasping breathing. and there is no gasping breathing here. And we can see there is no asynchrony also. All the waves are fine and there is no asynchrony. So that's the advantage of identifying the problem of dead space and removing it. Coming to the next part of my talk, that is compliance and resistance. Compliance of the lungs is defined as the change in volume per unit change in the pressure. It is expressed in ml per centimeters of water. It is very easy to understand. If there is a good change in the volume for every change in per every unit change in the pressure, that means lung is nicely compliant. If there is less change in the volume per unit change in the pressure, the lung is poorly compliant. While elastance is the tendency of a structure to return to its original form after being stretched. So basically, elastance is exactly opposite of compliance. So if compliance is C, elastance is E, the compliance is equal to 1 divided by E. They are opposite to each other. Compliance is change in volume divided by change in pressure. That is delta volume divided by delta P. So elastance will be delta P divided by delta volume. Compliance of the respiratory system, CRS, is the sum of the compliance of the both lung parenchyma as well as surrounding thoracic structure. So when you call it respiratory compliance is not just compliance of the lung parenchyma, it is also compliance of the thoracic structure. So this brings us to the important terms static compliance versus dynamic compliance. Static compliance means change in the tidal volume divided by P Plateau minus P, where Plateau pressure means it's alveolar pressure. So static compliance is basically talking about lung compliance, while dynamic compliance is change in volume divided by change in volume is nothing but tidal volume. Tidal volume divided by PIP minus PEEP, where PIP, if you are taking, that means you are including airway resistance, as we saw in earlier slides. So that means you are taking airway resistance as well as alveolar pressure. You are taking both. So this is respiratory compliance. This is dynamic compliance. So the pressure volume loop is a useful bedside tool to assess the lung compliance. This is a normal pressure volume loop during spontaneously breathing patient. So it is a clockwise ventilation, and during inspiration it becomes negative and during expiration it becomes positive. How it becomes negative and positive we have also already discussed in the earlier part of this talk. When a patient is on mechanical ventilation, it becomes anti-clockwise. So this is a pressure volume loop in pressure control mode, and this is on volume control mode. As we can see in pressure control mode, it is more box-like, because in pressure control mode, the pressure is fixed. So as soon as the inspiration starts, that pressure is achieved immediately with the very high flow in the initial few milliseconds of inspiration, and then subsequently that pressure is maintained till the end of inspiration, and then the expiration starts. While in volume control mode, the pressure is changing. That is why you can see there is no box shape, it is fusiform. So you can have this kind of shape in volume control mode. I won't say lower inflection point or upper inflection point as such over here. Why am I saying that? I will explain in the subsequent slides. This is in pressure control mode. You can see it is box shaped in pressure control mode because pressure first reaches the PIP, which is fixed, and then it remains constant. And in volume control mode, the pressure volume loop morphology is different. It is more fusiform, and it changes like this. So the pressure volume loop has different morphology in pressure control mode and volume control mode. And when there is a poor lung compliance, then this becomes more acute. In volume control mode, we are talking about, as I said, the compliance is assessed better in pressure volume loop. In volume control mode, you will see this angle becoming more acute. It is going nearer to the x-axis. So this is a volume control mode, and in volume control mode, you have a poor lung compliance in severe ARDS, and you can see the PIP keeps changing in volume control mode. As the compliance is improving, you will see the PIP is reducing, or plateau pressure is also reducing, and the angle, which is more towards the x-axis, is becoming more away from the x-axis now. So angle is improving, and this is much better normal lung. So as the lung compliance improves, you will see the angle changing away from the x-axis, and you can also see the pressures also reducing. So initially it was high pressure, and the pressure is reducing as the compliance is improving. This is in volume control mode. While in pressure control mode, the tidal volume changes. Pressure is fixed, and as I said, in pressure control mode, it is box shaped because pressure is fixed. In severe ARDS, you will have lowest tidal volume, and as the compliance improves, the volume goes on improving. In normal lungs, you will have maximum lung volume. So you can assess the compliance in pressure volume loop, in pressure control and volume control mode in different ways. In volume control mode, you will see pressure falling. In pressure control mode, you will see tidal volume rising as the compliance improves. Now, what is the static PV loop? So till now, whatever PV loops we saw, they are not static loops, they are dynamic loops. So we will see this is a static loop. This is actual PV loop with a lower inflection point and an upper inflection point, and then there is an expiration. So to understand the concept of static loop, we need to understand the equation of motion, which says that airway pressure is equal to lung volume divided by respiratory compliance plus gas flow multiplied by airway resistance plus convective gas acceleration minus the pressure generated by the muscles. So there are so many things which are involved in the equation of motion. So in a static PV loop, when we sedate and paralyze the child properly, what we are doing is we are basically removing the component of the pressure generated by the muscles by proper paralysis and sedation. And when we apply certain techniques like a super syringe technique or very low flow technique, I will discuss those in the subsequent slides. We are removing the confounding factor of airway resistance, and when we do that, we are basically removing the component of gas flow, airway resistance, and convective gas acceleration. So now, after providing sedation, paralysis, and using techniques like super syringe method or low flow technique, we are basically creating a situation where you have to deal with only lung volume and respiratory compliance and airway pressure, only these three things. And then you will see the lung compliance in a much better light. You will see in a much better situation. This is basically a static method. So if a patient is not sufficiently sedated, if patient is having spontaneous breathing, then your PV curve may not be representative of the lung compliance properties, because it will include the effects of respiratory muscle power. Thus, to get to know true lower inflection point, we need to sedate and paralyze the patient to remove the confounding effect of skeletal muscle activity. And by using special techniques like super syringe or low flow insufflation at low rates, etc., we need to remove the confounding effect of gas flow and airway resistance. Now let us understand what is this super syringe and what is this low flow insufflation at low rate technique. Super syringe method is a classical static loop technique where there is a large syringe with which they are inflating with 100 ml increments of gases and providing around 23 to 25 seconds to equilibrate, and then they make the measurements. This is also known as gold standard for measuring the static compliance. So various intervals, they will through a special syringe, super syringe, they will instill 100 ml, wait for 30 seconds to 50 seconds, and then take the measurements, and then again push 100 ml, and thus they will keep on pushing and keep on measuring, and thus they will get multiple dots of various compliances at different levels of pressures and volumes, and they will draw this pressure volume loop based upon the super syringe method. The disadvantage is, of course, it is very time consuming, and we need to keep disconnecting the patient for the measurements and for pushing the air, 100 ml of air inside every time. So that is the disadvantage, but it is a very classical method of properly achieving a static PV loop. The second technique is a low flow technique, where you are providing a very slow flow rate of gas, so that the gas is flowing so slowly, there is hardly any resistance created by the gas in the system. And that's why the airway resistance and flow confounding factors are removed from the equation of motion, and you can have a static PV loop situation. So after removing the confounding factors of skeletal muscle activity and airway resistance, if the lungs are normal with good amount of FRC, you will have a static PV loop like this. Here you can see here there is no lower inflection point. So in a normal PV loop with normal lungs, there is no lower inflection point, as you can see here, because lower inflection point is mostly seen in those situations where you have some 20 to 30% of alveoli which are under recruited, and when you applied some PEEP, they open up and they show some deflection. In a normal lung where most of the alveoli are open and you have a good FRC, you may not have a lower inflection point in normal lungs. But if you have a person who is being ventilated normally without any low flow technique at low rate or anything like that, or not sedated proper completely, not paralyzed completely, then you will have this kind of bulging in the pressure volume loop. This is not the lower inflection point of the static PV loop. This bulging is simply the deflection in the pressure because of the excess amount of gas flow creating airway resistance, and it is actually not representing the lung compliance as such. So that we need to understand. So if we see in this particular situation, we are we are measuring the PV loop normally. This is a normal PV loop at a certain peak. Here the peak is 6, and you can see here some lower inflection point also you can see in this particular situation. Now a low flow will be created, so the flow is reduced and rate is reduced, respiratory rate. We are reducing the rate to very low rate of 6, and we are reducing the flow to 6, and we are creating a low flow situation. In subsequent, so we are keeping the PEEP also 0. So in this video, you can see we are making PEEP also 0. In the subsequent, you can see a few seconds. So here we can see at 0 PEEP, respiratory rate of 6 per minute and gas flow of only 6 or 7 liters. You've got a static PV loop, which has got almost no lower inflection point. So if we compare, this is a normal gas flow. At normal gas flow at a PEEP of 6, you have some kind of this deflection, lower inflection point. But this is actually not a lower inflection point as we discussed. This is because of some muscle activity and because of the normal gas flow at around 15-20 liters per minute, creating some airway resistance and bulging. But when we remove that gas flow to 6 liter and rate of only 6, there is hardly any airway resistance now. And you can see there is no inflection point at 0 PEEP. So this is a static PV loop, and a static PV loop in a normal lung will not have any lower inflection point. So this is one more example. Here we have actually produced even more low flow at 2 liter per minute only with a respiratory rate of 3 per minute, I ratio of 3:1. And you can see absolutely straight line. There is no lower inflection point at all because this lung was absolutely normal. So once again, an example that in a normal lung, you may not have a lower inflection point at all if you create a static PV loop. In a normal PV loop, which we see in normal practice, you have a bulging, which we call as lower inflection point, but it is actually because of excess amount of airway resistance and muscle contribution of muscle contractions. So there is one more technique where the tracheal sensor is there, and this sensor is inserted in the trachea, and it measures the pressures and volumes directly at the level of the carina. So it eliminates all the contribution of the gas flow, airway resistance, etc. And we can see in this video, this inside one, the white one, is the static PV loop, and the outside bulging is the normal PV loop. And you can see this bulging is all because of excess amount of normal gas flow, and inside PV loop does not have any lower inflection point or upper inflection point because lungs are essentially normal. So this is what I thought I should discuss. Now coming to the last part of my talk, that is the flow, inspiratory time, time constant, and airway resistance. And we know the flow time scalars are different in pressure control and volume control mode. In pressure control mode, we have a decelerating flow. In volume control mode, you have a constant flow. All these things will be discussed in more detail in the talks on pulmonary graphics. This is the constant flow of volume control mode, and this is decelerating flow of pressure control mode. And the flow, basically this initiation of flow, peak flow, then constant flow, cessation of flow, then the state of no flow, and then expiration starts. So pulmonary mechanics wise, you have this uh, as inspirated time, and you have a total cycle time. And when you look at expiration, you have peak expiratory flow, end expiratory flow, and this is your duration of expiratory time, and this is your total available expiratory time. So in the flow volume loop, you have this inspiratory peak inspiratory flow and peak end expiratory flow. And since, as we discussed already, it is a constant flow in volume control, that is why it is flat on the top in volume control mode. While in pressure control mode, there is decelerating flow, that is why it will have a decelerating effect during inspiration and in the pressure control mode. So this is pressure control mode, flow volume loop. This is volume control mode, flow volume loop, flat at the top, decelerating at the top. Expiration in both pressure control and volume control has decelerating flow. So they will have similar pattern during expiration. This concavity in pressure time scalar in volume control mode is a sign that there is a flow starvation. That means the child requires excess more flow, but the ventilator is not providing enough flow. This is a sign of flow starvation. So which is seen in volume control mode. You can see the concavity scooping of the pressure time scalar on volume control mode. This is a sign of flow starvation. This is a sign of excess amount of flow.
In this video,
So this is because of excess amount of flow. So when we check the flow here, that flow by mistake somebody had kept at 70 liters per minute, leading to this kind of graph. And when we changed the flow down to the suitable flow, everything got corrected, and things were fine. So this is a famous Pauli's equation where radius is equal to 8 rho L divided by pi r raised to 4, where capital R is the resistance, capital L is the length of the tube, and rho is the viscosity of the gas, small r is the radius. We can see that the airway resistance is inversely proportional to its radius raised to the fourth power. That means if the airway lumen is decreased to half, the resistance will increase 16 folds. And that's a very important point. And we need to always remember to intubate with the appropriate size endotracheal tube. Smaller size endotracheal tube will increase the airway resistance tremendously, leading to problems of ventilation. Airway resistance is also calculated by Plateau pressure minus positive index pressure minus divided by gas flow. So now coming to inspiratory time and time constant and airway resistance, flow will continue as long as the pressure gradient remains between the two ends. So when the pressure equilibrates at two ends, the gas flow will end. It takes some time for the pressure to equilibrate between the two ends, from the supply of the ventilator end to the alveoli. And the time required for the pressure gradient to equilibrate depends on two variables, the compliance and the resistance. So the time constant, that is the time required to equilibrate for the gas from the source and the alveoli, depends on the compliance multiplied by resistance. Thus, time constant is equal to compliance equation is Vt divided by Plateau pressure minus PEEP, and resistance, as we discussed just now, Plateau pressure minus PEEP divided by gas flow. So the Vt is expressed in ml, Plateau pressure minus PEEP is expressed in centimeters of water, gas flow is expressed in terms of ml per second. So if they cancel mathematically, we are left with only seconds, and that's why time constant is appropriately represented in the unit of seconds. Now question is how to set up a time constant. So it takes one time constant for 63%, two time constant for 86%, and 3 time constants for 95%, and 5 time constants for almost complete pressure or volume equilibrium relation to happen. This is very important. So generally 3 to 5 time constants are required for good equilibration, and inspiratory time should be set in such a way that at least 3 time constants are provided for equilibration of the gas. So in this particular scenario, the time constant we can remember as per age how much I time to be set, but the more ideal method will be to look at the flow time scalar and adjust the time cycle. So in this particular case, we can see the flow time scalar here. The flow time scalar is not even touching the baseline completely, and the expiration is starting. So when we look at the I time is only 0.4 second here. So we decided to increase the I time to 0.6 second in this case. And when we increase to 0.6 second, we can see now the flow is now touching the baseline and then expiration is starting. Earlier, you can see the flow is not touching the baseline and expiration is starting before that. And after adjusting the time, I time properly, you can see the flow time is touching the baseline and then expiration is starting. So you can adjust appropriate I time and provide good time constant by looking at the flow time scalar and ensuring that the flow touches the baseline and then the expiration begins. Always expand the lung during expiration. Airways expand during inspiration and narrow during exhalation, as we know, because the chest wall lungs is collapsing during exhalation, so the airways narrow more during expiration. That's why expiratory time constant is longer than inspiratory time constant, because airway resistance is greater during expiration. The discrepancy becomes more pronounced in diseases of increased airway resistance like asthma or any abnormal vascular ring around the airways, where the expiratory time constant is markedly increased to the point that the equilibration at the end of expiration does not occur, resulting in significant hyperinflation and development of auto PEEP. So as we know, time constant is equal to compliance into resistance, and increased airway resistance naturally will require greater time during inspiration and expiration for the pressure and volume equilibrium to occur and airflow to cease. Conversely, in patients with diseases of decreased compliance like pulmonary edema, ARDS, the pressure and volume equilibrium occurs quicker. So this is important. Their time constant will be actually shorter. So if we compare a normal lung, even with this time of time constant, poor compliance patient will have volume equilibrium occurring much earlier compared to normal lung, while in patients with increased airway resistance, the time constant is longer and it takes much longer time for volume equilibrium. So patients with increased airway resistance require longer I time as compared to poor lung compliance. So increasing I time will improve the tidal volume delivery during inspiration, and increasing expiratory time may improve removal of tidal volume during expiration in patients with increased airway resistance. While in patients with pulmonary edema or severe ARDS, increasing I time won't affect delivery of I time. It may improve the recruitment of the alveoli or keep the alveoli open, better pressure delivery during inspiration. That is different thing, but it won't affect tidal volume delivery in those with poor lung compliance, because their tidal volume is mostly delivered in the initial phases of inspiration due to short I time constant. Now, here in this situation, the flow is not reaching the baseline during expiration, although the expiratory time is sufficiently long. And this is typical in patients with the increased airway resistance like bronchial asthma because of air trapping. It is not because of short I time, expiratory time. Here, in this case, you can see expiratory time is sufficiently long, but still expiratory flow is not reaching the baseline. So this is because of air trapping. Clinically, we can see here that the expiratory flow is not reaching the baseline. Here also we can see expiratory flow. In spite of that, expiratory time is so long, the expiratory flow is still not completely reaching the baseline. And in pressure time scalar, when you apply an expiratory hold, you will see some pressure which is trapped in the during expiration, which is called as auto PEEP or intrinsic PEEP. So when we apply, like in this case, there is a set PEEP of 8. You can see on the ventilator, PEEP is set at 8. And when we apply an expiratory hold, we are applying an expiratory hold for a few seconds, and then we look, we have this PEEP of 12 after applying expiratory hold. Set PEEP was 10, and then actual PEEP is 12. So there is a intrinsic PEEP of 4. So we have an auto PEEP in this particular situation, and that's how we measure the auto PEEP. Now, flow volume loop is a very good loop for assessment of the airway resistance. This is a normal flow volume loop with the good peak inspiratory and expiratory flows. When there is a bronchospasm, you will see the volume coming down because of bronchospasm and the flow not reaching the baseline because of air trapping. And when you provide good bronchodilator, sorry, like Levolin nebulizations, Maxelf, IV Maxelf infusions, then you will see the volume improving and the flows again touching back to the baseline. So flow volume loop is a good loop to assess severity of the bronchospasm and also response to various medications which we are using for treatment of air trapping and bronchospasm. Coming to the pressure volume loop, which you see in pressure control mode, and we see that in pressure control mode, you have a decelerating flow, and you need to provide sufficient time constant or I time, because if you don't apply that, the tidal volume will not be delivered properly. So in PC mode, the amount of tidal volume depends upon the available time because there is a decelerating flow, and that is why you need to have sufficiently long I time. So even during situations of bronchospasm, uh, in PC mode, you should have a sufficiently long I time so that your inspiratory flow, that is tidal volume, is adequately delivered to the patient. At the same time, you should have sufficiently long expiratory time so that your expiratory flow also should touch the baseline and there should not be any air trapping. So in pressure control mode, you should have sufficiently long inspiratory time as well as sufficiently long expiratory time in patients with bronchospasm to make sure that tidal volume is also reaching the alveoli properly and the volume is also exiting the alveoli properly. But in volume control mode, that is not a problem because in volume is fixed, and even if the I time is shorter in volume control mode, you can still manage to deliver the time, all the tidal volume in shorter I time. So this is how you should understand the importance of time constant and inspiratory time in patients with asthma. You need to have shorter I time, longer expiratory time in volume control mode, but in PRVC mode or in pressure control mode where there is a decelerating flow, I time you cannot keep very short because you have decelerating flow. You need to keep sufficiently long I time to ensure tidal volume delivery properly, and then you should have a sufficiently long expiratory time to ensure all that volume is out also. Coming to the concept of driving pressure, this was the famous study published in year 2000. That's called ARTSNet study, where they showed that lower tidal volume decreased the mortality. So then what happened is everybody started ventilating patients at 6 ml per kg of tidal volume, and everybody was assuming that lungs are like this, ventilate at 6 ml per kg tidal volume, because before that patients being ventilated at 10 or 15 or 15 ml per kg tidal volumes. So after that they started at 6 ml per kg tidal volume, hoping that this volume will reduce the mortality in all patients. However, in reality, in moderate to severe ERDS, lungs can be something like this, and lot of lung can be atelectatic and completely consolidated, and very few parts of the lungs may actually be available to receive the tidal volume which you are giving. So even that 6 ml per kg tidal volume which you are calculating per kg may not be may be too much actually, because you may not have enough amount of normal lungs to receive that tidal volume. Hence, it is recommended to calculate tidal volume as per available respiratory system compliance rather than as per body weight. And this was an important study published in NEGM in 2015 by Amato et al., which showed that this particular strategy of titrating tidal volume based upon respiratory system compliance that is called driving pressure, was associated with improved outcome. So driving pressure is basically tidal volume, which is titrated to available respiratory compliance. And at the bedside, it is calculated as Plateau pressure minus positive end expiratory pressure. And why? Because mathematically, respiratory compliance is equal to Vt divided by change in pressure, that is Plateau pressure minus PEEP. So if you take driving pressure, it is Vt divided by divided by Plateau pressure minus PEEP. So Vt will cancel each other, and you will get driving pressure is equal to Plateau pressure minus PEEP, and that's why driving pressure is measured at the bedside as Plateau pressure minus PEEP. So this is how driving pressure is measured, and this means that we need to be very accurate in measuring the Plateau pressure accurately, because if Plateau pressure is not measured accurately, driving pressure will not be measured accurately. So as we know, the modes of ventilators are important. This will be discussed in the talks on modes of ventilation further. So, but for this lecture, we need to understand that we have pressure control mode with decelerating flow, volume control mode with constant flow. And because of these different flows, measuring Plateau pressure is not easy. Both can have a good pause time. As we discussed already, depending upon the time constant, you should have a sufficient I time. I time should be in such a way that the flow should touch the baseline, then expiration should stop. So this particular gap of flow reaching the baseline during inspiration, and then after a few milliseconds expiration starting, this is called pause time. You should have sufficient pause time. Adequate pause time allows attainment of zero flow, so that we can apply inspiratory hold and measure the Plateau pressure accurately. So this is a volume control mode of ventilation, and in this volume control mode, there is a sufficient pause time we can see here, and with this is a volume control mode, sufficient pause time, and we are applying inspiratory hold of like 3 seconds, and then after 3 seconds we will measure the Plateau pressure. So this is our sufficient 3 seconds of this thing, and you have a Plateau pressure here which is 15. So you have a peak pressure of 21 and Plateau pressure of 15 centimeters of water. This is how you measure Plateau pressure. You have a sufficient pause time here in flow time scalar. So this is how you measure Plateau pressure in volume control mode. In pressure control mode, again, you need to make sure that your I time is sufficiently long so that your decelerating flow is touching the baseline, and then apply inspiratory hold just like in volume control mode and measure the Plateau pressure. So this is how it is. This is a pressure control mode. There is a decelerating flow with sufficient inspiratory time, and we are going to apply inspiratory hold just like in volume control mode for 3 seconds, and we have a good the flow touching the baseline and then expiration starting, so good pause time. And here we can see Plateau pressure has come 15, so we have a peak pressure of 15 and Plateau pressure of 15, and the flow is touching the baseline. So this is how you measure Plateau pressure in pressure control mode. Both volume control and pressure control mode, you need to apply inspiratory hold to measure the Plateau pressure, but before that you have to make sure that the flows are touching the baseline during inspiration before starting of expiration. Now coming to the concept of mechanical power, this is for the sake of the talk on pulmonary mechanics. I thought I should cover this also, because this is something which is new, and it involves all the pulmonary mechanics aspects in one equation. So we saw various pressure and non-pressure mechanical factors, pressure factors like Plateau pressure, PEEP, driving pressure, and non-pressure factors like tidal volume, airway resistance, IE ratio, respiratory rate. They are all basically components of energy load, and they can cause ventilator-induced lung injury. So these all pressure and non-pressure parameters, when they are expressed in joules per unit of time, they are called mechanical power. So geometrically, when we calculate, the left catheters of the big triangle represents the total volume. So this side, left side, is PEEP volume and tidal volume, and this part is represented by the airway resistance, and the upper part is represented by the pressures, that is positive and inspiratory pressure. That's our Plateau pressure. This is alveolar pressure, and this is your peak inspiratory pressure. And this slope of the hypotenuse represents the compliance of the system. So naturally, the plateau pressure minus PEEP is the driving pressure. So when we rotate it by 90 degrees and then keep it besides pressure time scalar for comparison, we can clearly see that this is PIP, this is plateau pressure, this is our driving pressure, and this particular part is our compliance of the system, of the slope. So the energy needed for the tidal volume to reach the plateau pressure is basically the product of this and this. That means the PEEP plus driving pressure multiplied by the volume displaced, that is PEEP volume and the tidal volume. This is basically energy load. So when you look at the equation, you have this part of the equation representing by the lung respiratory elastance and the tidal volume. Then your resistance part, airway resistance part is represented by this part of the equation, and the last part, that is PEEP component, is represented by this part of the equation. So you have the elastic component, resistive component, and the PEEP component, and when they are all multiplied by respiratory rate, then you call it as mechanical power in joules per minute. So basically, area under pressure multiplied by area under volume, when you take that area and multiply by respiratory rate, that is your mechanical power, you have energy. So this is the equation given by Gattinoni in 2016 about calculating mechanical power in volume control mode. Then subsequently, Becker et al. Came up with a mechanical power equation for pressure control mode also. So you have energy to distend the lung, to move the gas, and to keep the alveoli open during expiration. And all these things, when multiplied to respiratory rate, is mechanical power. Each component of the mechanical power equation can cause ventilator-induced lung injury, and that impact of injury is more at higher rates and longer duration. Advantage is obvious. This equation provides a description. It basically enables us to for quantification of relative contribution of different components. So looking at the equation, we can clearly see components in individual contribution of components, how much tidal volume is contributing, how much respiratory rate is contributing, how much positive end expiratory pressure or gas flow is contributing in ventilator-induced lung injury. So, for example, here we can see the mechanical power is contributed maximally by tidal volume, gas flow, and driving pressure, and then subsequently by respiratory rate, and least by the positive end expiratory pressure. So when you have a situation of poor lung compliance, you reduce the tidal volume. So when you reduce the tidal volume, basically you are reducing the mechanical power. But when you reduce the tidal volume, you are also exposing the possibility of atelectatic trauma. So then you increase the positive end expiratory pressure to counter the effect of low tidal volume and atelectatic trauma. So, but the bargain is reducing tidal volume will reduce mechanical power much more, and increasing the PEEP will counter atelectatic trauma, but it will not increase the mechanical power that much. And that's how low tidal volume and high PEEP strategy will work in patients with ARDS. So mathematically, from mechanical power equation, you can explain few things in this manner. So to summarize, ventilator delivers gas to the lungs, as we saw, using positive pressure at a rate. The amount of gas delivered can be limited by time, pressure, and volume, and the duration can be cycled by time, pressure, and flow. The speed at which the gas flow delivery completes would depend upon the underlying lung compliance and the airway resistance, which is time constant. We discussed that. Children with higher airway resistance will have longer time constants. They will need longer expiratory time in VC mode. But in PC mode, they will need longer inspiratory time as well as longer expiratory time. Longer inspiratory time in PC mode is required because they have decelerating flow, and that's why they need little longer time for the flow to touch the baseline and deliver all the volume. So PC mode means PC mode as well as PRVC mode. Airway resistance is best assessed in flow volume loop. We discussed also. how we can assess the airway resistance and response to treatment when we are applying bronchodilatory treatment for airway resistance issues. Auto PEEP is best assessed in pressure time scalar. That also we saw how to apply the expiratory hold and assess the auto PEEP or intrinsic PEEP. Compliance is best assessed in pressure volume loop. We also saw how to assess compliance in pressure volume loop in pressure control mode, where the pressure is fixed. That's why we will see the tidal volume improving as the compliance improves. And in volume control mode, where volume is fixed, so we will see the pressures reducing, the peak inspiratory pressure is reducing as the compliance improves, and the angle also becomes less acute as the compliance improves. Improvement in the lung compliance during VC mode is reflected in smaller driving pressure to deliver the same tidal volume. So in VC mode, we can also look at driving pressures, but in PC mode, driving pressures are fixed because your PIP is fixed. So in PC mode, we will see higher tidal volumes for the same driving pressure. In children with poor lung compliance, it is preferred to pay attention to driving pressure, titrate the tidal volume as per available respiratory system compliance. That is very important. Titrating tidal volume to available respiratory compliance. If lungs are normal, you can ventilate it as per tidal volume as per predicted body weight. But when the lung compliance is poor, you have moderate to severe ERDS or severe pulmonary edema, then you have to keep a watch on the driving pressures. And in children with poor chest wall compliance, the airway pressures displayed on the ventilator screen may not be the actual pressures delivered over the alveoli for their distension, and hence measurement of the pleural pressures, for example, by esophageal balloon pressure monitoring. There are other methods also for pleural pressure measurements, and then you can calculate transpulmonary pressure. That may be a better approach, although it is still not validated in children. Thank you very much.